Introduce myself. I'm a board member and VP here at ALK Positive Canada. I was diagnosed 4 years ago with ALK positive lung cancer in Toronto, and I had my care at the Princess Margaret Hospital. But now I do reside in Victoria, BC. It's really exciting for me to have you all here tonight and have a great session with our guest, Dr. Geoffrey Liu, who is a medical oncologist at the Princess Margaret Cancer Centre, focusing on ALK or ALK cancer. He has opened 19 ALK and 6 ROS1 clinical trials at the Princess Margaret Cancer Centre and brings a wealth of expertise to this conversation tonight. So welcome, Dr. Geoffrey Liu. We truly appreciate you taking the time to connect with the ALK positive cancer community here in Canada. This is really a first of its kind event, and I think it's just nice to have this representation and community here finally in Canada. So for today, I know you have a few topics you're going to cover, and then I will go back to the Q&A afterwards and walk through some of these questions that we've collected from the community here. So with no further delay, I'm going to hand it over to you, Dr. Liu.
Sure, thank you. I actually go by Jeff, so
Perfect,
please
Jeff.
call me Jeff. I have one slide and only one slide, so I'm going to put that up. I'm hoping it'll work. Hang
I do
on.
see it.
Okay, right. And that's just to make sure that that we all know which drug we're talking about at any one time. So I'm a medical oncologist at Princess Margaret. I do specialize in ALK and also in ROS1. They are quite related to each other, and some of the drugs actually work for both in this particular setting. I'm going to give really just about maybe 3 or 4 minutes of just a quick introduction to make sure we're all on the same page. When I started, ALK positive patients had basically very little to be offered back in 2009 and 2010. 2007 was when it was described as a target that was found in lung cancer that we could potentially have drugs for. And the first drug, crizotinib, went into trials soon after that in 2008 and 2009. My first trial for ALK was in 2010. We put the second patient in the world on ceritinib, a drug that's no longer used, but at the time was a salvage drug, a drug that was used after people had been on crizotinib and then had disease that grew from there. And the first two drugs on the list, crizotinib and ceritinib, are no longer used to this date, with very few exceptions. I think there are a couple of patients I know who've been on the drug for more than a decade. And so if something's working, you don't fix it, you don't change it. So they're still on those drugs, but the vast majority have either moved on or were diagnosed more recently. So the next three drugs on the list, alectinib, brigatinib, and lorlatinib, which includes the one with the red arrow and the one with the blue arrow, are the ones that we're mostly going to talk about, because these are the drugs that that most of the patients are on at this time. And all three drugs are good drugs, and all three drugs are available pretty well in, I think, practically all provinces in Canada, and have been approved for use by Health Canada. The last drug at the bottom, neladalkib, I just realized that I'm missing an A in that word, neladalkib.
It's a
Um,
tough one.
yeah, and particularly since the missing A forms the A in the ALK in the middle of the word, is Nuvalin 655, and it now has a name, and that is a drug that has just recently been in clinical trials and is now available compassionately in Canada with a few restrictions and limitations. So these are the drugs that I think I'll be answering questions about. A few things that are important to note. Many of you have probably realized that the majority, not all, but the vast majority of patients who have ALK positive lung cancer do not fit the typical description of a lung cancer patient. Because, when I talk to my friends and family, their idea of lung cancer is heavy smoker, in their 70s and 80s. And this group in particular has over 80%, in some cases, almost 88 to 90% of individuals have either never smoked or smoked extremely lightly. It's a completely different population, much healthier, younger population. Many of you will have perhaps children that are in high school or even in elementary school, or university, as opposed to having kids that are fully out there into the world. And so it's a younger, healthier, fitter population in general, with fewer diseases, because it's a relatively low smoking rate that we're dealing with. So it's completely different type of cancer than what a lot of people around Canada and around the world think of as being associated with lung cancer. And I think we need to acknowledge that. So that's one of the things that I'm sure will come up in our discussions. We don't really understand why there's been almost an epidemic of growth in individuals with lung cancer who have never smoked or smoked very lightly. I know that when I started a quarter century, actually slightly more than a quarter century ago, if a patient showed up with lung cancer and they told me they had never smoked before, I would be suspicious that this might not be lung cancer. It was a mistaken diagnosis, or the patient was lying to me, that they were too ashamed to be labeled a smoker. I don't think like that anymore. In places where there's a high proportion of individuals who are never smokers, like Toronto, 11% of adult Torontonians are current smokers, and even slightly lower in Vancouver. We have upwards of a third of our lung cancer patients that show up at our hospital are lifetime never smokers. And that is way larger than it was a couple of decades ago when it was like 5%. So I want to put it out there that if many of you have been feeling for a while that what you hear about lung cancer doesn't fit who you are, I put it out there that that's part of our messaging, that we need to get it out there. If you have lungs, you can have lung cancer. And then one of the biggest problems now is trying to figure out, usually family doctors are very aware that if you're coughing and you have issues and new symptoms and you're a heavy smoker, they think of lung cancer. But it's not out there. The fact that if you've never smoked, you can still have lung cancer if you have lungs. And so all of these things I think are important for us to think about, both for ourselves and because we also are realizing that family history now does play a role in the sense that if you have been diagnosed with lung cancer, your blood-related relatives, particularly those who've never smoked, are at slightly higher risk of developing lung cancer as well too. So we need to kind of figure out for the next generation, how to diagnose lung cancer early, as well as how to better treat it, better cure it, and better control it for long-term control. So with that, I will stop right now. And maybe Katie, did you want to start asking some of the questions or?
Yeah, and I just want to say that I think it's great that you pointed out the shift in mindset. I think with lung cancer, there's the traditional risk factors that everyone still walks around with, largely around working in a place or an environment that might be hazardous to your lungs, smoking, and I think the traditional risk factors that we've all known, and then probably even clinicians have well known, is not keeping up with what we're seeing today. And so I do appreciate your comment around, that needs to change as well. We need to shift the mindset. It resonates well, I think, for all of us. So I will jump into some questions. I think what I'll do is the first part is mostly around kind of regular scanning, what should we do, treatment options today, and some ALK positive questions. And then the next set are more or less clinical trials. So the first one we have here is what is the value of regular PET scans? So PET specifically, and what is the recommendation for how often those scans should happen after being diagnosed?
So this really speaks to the idea that ALK Positive Canada really needs to exist, because without the word Canada, what we basically get is what I call American in influences, and I think we all realize that some American influences are not necessarily applicable to us to a great extent. In the U.S., basically, you sneeze and you get a PET scan. In Canada, they are often restricted by the government based on available data. So the rule of thumb is at the time of diagnosis, um, a PET scan is often considered important to get in order to figure out whether the disease has spread beyond its initial area or not, or to figure out the extent of disease. After that, PET scans are not particularly useful for tracking patients on an ongoing basis. In fact, one of the issues at hand is that CT scans with intravenous contrast injection are mostly thought to be at least as good, if not better, than PET scans at tracking where we know the cancers to have existed, and also to track new lesions moving forward. They happen to be cheaper, so from a healthcare perspective, it's more economical to do a CT scan than a CT PET. If you have the capability of getting a CT PET, sure, which is what happens in the US. In reality, we do very well in Canada with getting a PET scan, perhaps at the time of diagnosis. But afterwards, tracking with CT scans are perfectly safe and perfectly fine. Tracking the brain, on the other hand, often, if possible, the preference is an MRI. Depending on where you live, that might not be possible, and a CT is a reasonable alternative for the brain. For the rest of the body, CT scans, I think, are perfectly fine to do so. We've not had any problems of missing things in patients because we did a CT rather than a CT PET. Just to clarify, a PET scan is actually a CT PET in most of Canada, and the CT scan I'm describing is a CT with intravenous contrast. Most places, when they do a CT PET, won't actually give IV contrast. So you get either the CT PET without contrast or a CT with contrast, and they're thought to be quite similar in the benefit for tracking and monitoring patients. So sorry, it's a very long answer for a very short question.
No, I think that's great. I think detail is great for this crew as well. And in terms of recommendations for how often someone should go, I don't know if you want to break it down by maybe
Sure.
stage or the history, but how often?
Sure. So I think the majority of you will be in the later stages. So stage 3B or stage 4, what's considered quote unquote incurable, although we're sometimes talking about people living years and years and years, that still carry that term. So I think of that term as a bit outdated. Um, but um, but actually, Katie, can you repeat the question? I just blanked out. What was the
Yeah, no,
question?
it's okay. What is the recommendation for how
Oh, yes, that
often
that's
scans?
about the
Yeah,
frequency. Yeah.
frequency.
So there are no specific rules when it comes to how often you should be tracking the disease. Usually, when we don't know the nature of the disease and the pattern of the disease at the beginning, I tend to do scans roughly every 3 months or so, right at the beginning. Once things stabilize, because remember that some of you could actually be on the same drug for 5, 6, 7, 8 years plus. Doing scans 4 times a year still becomes quite a lot over time. Once you get a sense that the disease is very, very stable over a period of time, I actually cut back to do it once every 6 months. And I might alternate between a chest X-ray and a visit, every 3 months, but not do scans at every visit, but rather every 6 months. Every oncologist is going to be different depending on their prior experiences. But once you get a sense of the fact that the disease hasn't come back in the last 18 months or so, then I feel pretty confident that we can stretch it out a bit longer.
Right. So you're probably
For
looking
most of
for
the
like
patients.
a certain length of stable
Exactly. Yes. Yeah. You
or
need to know the nature of the disease, and the fact that most of these drugs, if it's a first drug that you're using, um, the failure rates are highest in the first year to 18 months. So if you make it past that period, you're probably, it's not a guarantee, but you're probably going to be at a much lower chance of failing that drug. If you've been stable on it for like a year and a half to 2 years or so. And even if you were, it generally is slow enough that you catch it, you have time to switch over to something else, and it wouldn't necessarily adversely affect your outcomes in that sense. And it's really a balance. I mean, some patients and oncologists can't sleep without doing scans every 3 months, so be it.
right.
There are
Yeah.
no hard and fast rules. There has to be a
Katie,
comfort level between the patient and the oncologist.
Katie, could I ask you
Yes.
to take the slide down so we can see all of
Oh,
Dr. Liu?
oh, oh, yeah, yeah, that's my fault. I need to stop sharing. Sorry, I didn't realize. There we
There
go.
we
How's that?
go. Perfect. That's great. Great recommendation.
Okay. Next question, Katie.
Next question is, what is the available second line TKIs today,
Oh
or
gosh,
what would be highly?
yeah, this is the big issue, and one of the reasons why I really feel that ALK Positive Canada and its members can maybe help us a bit. So historically, um, um, there are two processes. There's a federal process of getting a drug approved that basically said the drug is safe and effective, and that's Health Canada. But then to get the provinces to fund that drug, it has to go through a second process. In this case, the agency's name has changed several times. It's now called Canada's Drug Agency, and they assess for cost effectiveness to make sure that we can afford it within our system. This is this ran into a bit of a problem because currently the first line approved drugs with public funding are alectinib, brigatinib, and erlotinib. And second line drugs that are approved for public funding, zero. We are the only jurisdiction or country out of 20 something different countries from around the world that doesn't have public funding for second line drugs that are currently used today. There's second line use of alectinib, but remember we pushed that for use in first line now. So, and what I mean by line is that first line means the first drug that you get. Second line is after something happens and the drug no longer works. What's the next drug that you can use? So this is a big issue. Some private insurers will cover lorlatinib. Lorlatinib has demonstrated benefit in this particular setting after alectinib or brigatinib, but it's approved for use in Canada. So if you want to shell out however much it is, between $8,000 and $10,000 a month, or you have private insurance, you could potentially get that drug covered. Um, you will not get that drug through public reimbursement, through public funding, and that's probably a very big issue that we might need to talk about down the line because I think that's where the advocacy comes in. It's embarrassing to hear that we don't have it in Canada, and that's because um, our our drug agencies do make mistakes. Many of us clinicians and patients feel that they made a really bad mistake by rejecting the actual data that suggests a good benefit of lorlatinib in a second line, after people have been previously been on alectinib and or brigatinib.
Yeah, and I think that brings into, something that ALK Positive Canada wants to be a combining force of everyone here and see what we can do to move as a collective more formally. And I think there's a lot of opportunity for that this year. we need to make a big change for anyone needing second line treatment across the board.
Yeah. And I think this is really, really important. Second line could be available in certain circumstances with neladalkib right now. And we'll go over that in a little bit when we talk about clinical trials and kind of what's up next. Um, the bottom line is that if you're stuck in a position in which you and your oncologist feel that, you're stuck, you can't afford the next line drug and so forth, talk to me, talk to other experts. Um, there are backdoor methods, none of which I can actually speak in public about. But there are ways for us to deal with this. It's just we want to be able to access this through the front door. It's only fair.
And we appreciate you being such an advocate for all of us. It's great. So I think we've covered actually quite a few questions and just your answer in that one. I will jump ahead to a question, which is why does each generation treatment, example, lorlatinib, maybe after alectinib, seem to have more side effects than the last? And maybe
Okay.
I'll add on to that as well. Like, do you see that or?
In fact, the second generation drugs have probably the least side effects right at the moment. There were more side effects with crizotinib than they were with alectinib. And there are more with alotinib. So it might appear like it's getting worse, but it's bouncing around. And it's specific to drugs, to the drug themselves. In the case of lolotinib, lolotinib targets several different targets at the same time. Alectinib primarily targets ALK with very little of targeting any other pathway. But lolotinib targets ROS1 as well. It targets ALK and it targets TrkB. And it's the TrkB problem because the TrkB side effect, there are TrkB receptors in the brain. And it's thought that it's those issues that lead to issues with potential changes in memory and mood swings and irritability and the very, very rare psychosis that can develop and some word finding difficulties in some patients. And it's due to the fact that it's targeting more than one pathway. So it's not the generation, it's just the drugs themselves. Some of them target only one pathway, some of them target more than one. Lolotinib definitely works well for ROS1 as well. We know that. But it runs into problems because it also has TrkB side effects because that often is tied with ROS1. Many of the ROS1 drugs also have TrkB side effects as well, namely entrectinib and repotrectinib. So I think because it crosses over, then it runs into more issues. A drug such as neladalkib, which is Nuvalin 655, the one in clinical trials right now, or just finishing clinical trials right now, is more of a pure ALK inhibitor, so it has fewer side effects than alotinib. So hopefully that'll help you understand, right? Like if a drug targets multiple pathways, then it also potentially can run into the side effects of targeting multiple pathways as well.
Right. And then, so the next question kind of tees up this well too. So let's say there were no rules from the CDA where you had to go, lorlatinib has to be first to be covered. Like, let's say everything is funded. Do you see that there's a path where, depending on the person and their symptoms, they should go on one versus another?
Right.
Or do you think right now, with what we know, do you think there is a very strong recommendation for a certain
Okay. So I'm going to preface this by saying if you've been on the drug that you've been on for a while now, a while meaning a year and a half at least, right? Do not randomly switch over to another drug. This is the bird in the hand syndrome. The bird in your hand is working, right? So don't because somebody says there's a shiny object next to you that's going to be any better. It's like mutual funds. There's no guarantee that if it works in somebody else, it's going to work in you, in this setting. So it's important to keep that in mind. With that prefaced, if you were newly diagnosed today, there's a very strong emphasis to actually give the best drug that we know right now, and that drug is alotinib. It's a third generation drug. It is beating alectinib on average. And remember, average doesn't mean you. It means you take a group of people, and this is the average value amongst that group. But that's the only thing that we can measure from a population perspective. And you gain, on average, more than 2 years by starting off with alotinib. You're able to stay on the drug on average for more than 2 years than if you started with alectinib, knowing that there's still other drugs beyond there that you could use. So with that in mind, it's by far the clear choice if you were just starting. But it also has a bunch of these weird side effects, and there are some individuals who may be unsafe or less safe starting with alotinib. And that has to be discussed with your local oncologist. I estimate, though, that the individuals that might run into problems with alotinib that we can tell upfront because of their past medical history or past issues might be only 1 in 5 patients. So 4 out of 5 should be able to start lolotinib in that setting. What we do after that is anyone's questions. So another question that will pop up is chemo any good in this setting? Chemo is actually quite effective for in the ALK positive setting. And sometimes we use that after we use 1 or 2 different of the pills of the what we call tyrosine kinase inhibitor pills, that we sometimes will use chemotherapy to quote unquote reset the clock before we then use a third tyrosine kinase inhibitor. So chemotherapy is definitely something that should be considered. And I have, in some cases, patients who've been on the chemotherapy for 2, 3 years, buying them more time. And then eventually, when they run into problems, they go back on to another pill.
Oh, I haven't heard of that. That's new to me. So thank you for explaining that. Is there ever a combination where you do it like more
You
combined or
mean,
it's very separate,
okay,
the
so
treatments?
we generally don't use 2 pills together because the side effects might be overwhelming since some of the side effects are right and they're targeting really the same thing. So if your disease is not going to respond to that target, then it doesn't matter how high a dose you give it, it's not going to work. Or if you give
Right.
all 4 drugs together, it won't work. But the combination of the pills and the chemotherapy occasionally have been able to keep people going for a while. How we can manage to give both in a publicly funded system, again, backdoor methods we discuss in private. But in some cases, a drug such as lolotinib is so effective in the brain that what happens is that when the drug fails the rest of the body. So let's say you have disease starting to grow in the chest again while you're on alotinib. You might need the chemotherapy to control the disease in the rest of the body. But sometimes if you stop the pill, then the disease comes back in the brain, and you need the pill for the brain and then the chemo for the rest of the body. So yes, under certain circumstances, we have used combinations in order to try to control the disease. It's very individualized. It's not something that we recommend for most patients. Um, but if the question is, have we ever done that? And has it ever worked? The answer is yes and yes. But please, please, please don't do this on your own. This is a carefully thought out, logical approach that is used in very specific circumstances in a very small subset of patients.
Got it. Okay. Thank you so much for diving into that. So I have 2 more questions, and then I'm going to jump into clinical trials. So both are kind of related to, well, one is, can you explain more around the family history connection? And the
Sure.
second is, why do some oncologists say that ALK positive is mostly prevalent amongst Asian women? And if you know
Okay.
anything around that.
Right. So the first question is you know what? I've just forgotten the first question because I was thinking about the second one. What was
That's
the first one again?
okay. It's never good to do 2 in a row. So can you explain more about the family history
Oh, the family
connection?
history, yes. So this came about from the fact that there are several large epidemiological studies that have looked at what are the risk factors in never smokers. Because, we know what the risk factors are in heavy smokers, right? That's pretty obvious. But we don't know, right? And so things such as radon exposure, arsenic exposure, secondhand smoke, there's a whole series of them. But one of the risk factors that has been identified is family history. Um, the vast majority of patients still won't have a positive family history. It's estimated that somewhere around 6 or 7% will. So it's not that often, but if you do have a family history, or now that you have, lung cancer, then your family members who are never smokers might be a slightly higher risk. It's still a very low risk, but it's something to keep in mind. And it's something that as we pursue this information more, it might be one of the recommendations eventually that we have to family doctors as to if there's a family member who has had a history of lung cancer and you're showing up coughing, don't wait for 6 months before, doing something about it. And don't ignore it for a very long time. We're not there yet, but we're trying to gather as much data as we can so that we can inform family doctors of issues like that. The second question is, what is this deal about Asian women? Well, um, in Taiwan, they did actually a screening study. They screened patients who had never smoked before, and obviously Taiwanese are generally, I mean, what you would call East Asian, of East Asian ethnicity. And there was a similar risk of identifying lung cancer in the never smoking females in Taiwan as in white, heavy smoking males in North America. So there's a sense that that particular group is at higher risk. And in fact, my practice, I guess the nature of Toronto is that we have a lot of visible minorities. I have probably in my practice about 20 to 30 East Asians, about maybe a quarter of my practice that are lifetime never smokers, all with lung cancer. The vast majority of them will have EGFR as the mutation. A smaller proportion will have ALK. We also know that risk is higher in South Asians as well. So when I did my speaking tour of India, ALK was seen in about 10% of lung cancers, much higher than what we see in Canada, which is somewhere around 2%, in this particular setting. So it's not just East Asia, it's also Southeast Asia, people from the Philippines, people from South Asia. There's a sense that maybe it's also higher in certain Afro-Caribbean communities as well. But you don't have to be, I mean, every ethnicity is affected by ALK. And it's just that some populations there's an even higher risk involved.
Yeah, I think for a lot of us, we want to know, especially if we have kids, or like what are the different risk factors that are different from what we talked about before,
We're
traditional. And so
yeah,
learning.
so we are working on this. In fact, we are going to be opening a website later this year called www.weareclans.ca. CLAN stands for Cancer of the Lung in the light and never smoking setting. It's meant to be a website that deals with ARE, as in We Are Clans, ARE, advocacy, research, and education. Because I think we need a forum for individuals who don't identify as a heavy smoker, to actually see that there are other people around you, and maybe not feel so lonely and so isolated at the beginning. But also, many of these individuals will have a targeted, will have a mutation that is targetable, like ALK or EGFR or ROS1. And so I need a way to gather all this together. And this is, one of the ways that we're hoping to do this. And that's where we're going to bring the researchers together. One of the things that we'll be asking people to do is to fill in a voluntary risk questionnaire, both you and any family members who have never smoked, because we're trying to identify risk factors in those individuals who have developed lung cancer versus those who haven't with never smokers. This is work that we're doing with Martin Tamamagi. He's a Canadian who's the guru of developing these risk models. It is one of his risk models that are currently being used across Canada and around the world to identify who's at high enough risk to undergo lung cancer screening right now. He's trying to extend that to include who should be So look for that website. We'll get Katie and Duncan to actually send things out when we are open. And the more people who actually sign up and fill in the questionnaire and so forth, the more information we'll have to maybe figure out what the risk factors are and how to cater that towards a Canadian population.
That's fantastic. It's great to hear that that initiative is being led here, right in Canada. So please do send along the information, and we're happy to share as well. So we're going to dive into, we have 20 minutes left, and we have probably so many more to get into. The clinical trials. So the first big question is, what clinical trials are available to Canadians right now?
Okay. So this has just changed in the last couple of weeks, but it's changed in a good way. Okay. Neladalkib, or the ALKO study involves that one drug, a fourth generation drug, that was in clinical trials and has been shown to be beneficial in a subset of patients after after patients have previously received either alectinib or lorlatinib or brigatinib or any combination of those. Um, so it was opened in 4 places in Canada, Vancouver, Edmonton, Ottawa, and at my site in Princess Margaret. And that's where you had to go in order to get the drug. The trial has just finished accruing. So in other words, it's met its target of several hundred patients from around the world. In at Princess Margaret, we actually have put on 23 or 24. The last patient was just dosed today, for the first time, having been accepted into the trial just a couple of weeks ago on the very last day that we could qualify the actual patient. So essentially, people cannot get into the trial anymore, but the company has actually generously offered the drug for free, conditional on Health Canada approval. So we now have to apply for every patient that wants this drug to Health Canada and to the company. The company is very lax in giving out the drug. Health Canada has its very, very strict mandatory rules because technically this drug has not gone through the assessment yet. It's not approved in Canada. And so Health Canada has basically said you have to use everything that is standard first. When you run out of options, then come ask us because they don't want to release the drug to everybody and anybody at this time. They will also only release the drug to those centers and those individuals who have previously used the drug. For obvious reasons, you can't have oncologists who've never used this drug, had no experience, right, use a drug that is not approved in Canada. But what we are doing is that, and certainly I am, and one of my colleagues out west in Alberta is doing, is that we're willing to work with patients across Canada and their local oncologists so that we will apply for the drug for them. We would do like a virtual visit, right? So they don't have to fly to visit us at all. And then we would chaperone and work with the local oncologists to actually monitor the patient, if the patient ends up qualifying and needing that drug. So that at least for now, we're hoping that we'll be able to get this drug out to those individuals who have no other options, who have used up lorlatinib and or chemotherapy. From what I gathered from my recent applications to Health Canada in the last couple of weeks, they would prefer patients have completed both, or if not, an explanation for why they either couldn't receive chemo or they couldn't receive lorlatinib. We have a list of reasons. Again, there are methods for us to deal with it, but in general, we now have access to that drug, neladalkib. Okay,
And
but
the
there's a
access is
there,
through
the acts.
a trial or the
No,
EAP?
no. It's actually neither. It's similar to EAP except it's called SAP. When the drug hasn't been even approved in Canada, it's called an SAP, Special Access Program.
Okay.
When it's approved in Canada, then it switches to Expanded Access Program. So it's under an SAP. An oncologist with experience with the drug is the one that has to apply to Health Canada. So I'm willing to chaperone any local oncologist and any patient through that process. At least one of my colleagues, Quincy Chu in Edmonton, is also willing to do that as well. So when in doubt, again, we ask people to contact us, and then we try to manage with them and their local oncologists to figure out if it's appropriate to try for that drug, or if there's other alternatives before then that are reasonable and not, not won't break the bank. And then if so, how do we apply for it? We'll work with the patient and the local oncologist on that. Our goal is
Okay.
to give people access as much as possible during this period.
That's phenomenal. Thank you so much for once again being a strong advocate for all of us and making sure that we can access. I think for many of us who are looking for a second line treatment, this is a promising frontier for us. But if we can't access it, that's the hard part. So,
Mhm.
so you've been able to cover quite a bit about the Nuvalent, or I'll try to say Nalaticalib.
Now, Lad Delkib. Yeah, I
Maybe
had
we
to.
can have a
I've been
session
practicing. I've been
on.
practicing it for the last few weeks. It takes a
You're,
while.
you've done a really strong job. Um, can you explain the clinical trial process in
Sure.
Canada?
Okay. Yeah.
So I know we're kind of out of the clinical trial process to a degree, but for the next one, or how can we get more comfortable? How does it get set
So,
up?
so
How
there
do
there
you
are
approve?
trials. Yeah. So there are trials that are coming to Canada. One of the ways in which we have to do that is that, we go approaching companies. Sometimes companies approach us. But a lot of times we have to hound the companies that are coming up with these drugs. So we go to meetings. There was a meeting in Huntington Beach just a few weeks ago, and there I got information about two new drugs. And so eventually my goal is to bring them to Canada. I can only offer them in Toronto because that's where I practice. But at least if it's available somewhere in Canada, then it at least is an option. And sometimes, often, my partner in crime, Quincy Chu, will open it out west in Edmonton as well. So we have at least two sites, and occasionally we get a site in Montreal and so forth. But it really depends on capacity. And so the trials start off in three phases: phase one, two, and three. Phase one is basically just trying to find the right dose. So it's often what we call first in man, which means that it's just starting to be used. Now, it sounds very guinea pig like, but in actual fact, like suritinib was approved on the basis of a phase one trial. Like sometimes when these drugs work really, really well, you actually see it being effective at lower doses, and you see it being effective almost immediately. It's very different than 2 decades ago when like all these drugs we would test and none of them would be effective. And now more and more, because these are targeted agents, we're actually seeing benefit in a reasonable proportion of patients, some often between a third to two-thirds of patients. So there's more hope, and even in the phase one setting. Phase one is really to figure out what's the dose, the maximum dose that's safe to give in a patient. Phase two is it effective or not? And phase three is basically comparing it with the standard. Many of our drugs will not undergo a phase three before it's approved because these drugs are so considered effective that we can see the benefit in the phase two, even without having to compare with the current standard. So most of the drugs that have been approved on the basis of phase one, phase two trials in ALK. The fact that this is a rare entity allows us to make the argument as well that it's too hard to do a phase three trial. It'll take forever. There are not too many patients around, right? So many patients are going to die unless you just approve this drug on the basis of phase two. And then there's a promise of maybe doing a phase three trial after the approval process is made, what we call a confirmatory phase three. So all of those things are things that are coming along. In the case of the ALK vaccine trial, we're working on it. We haven't got a commitment yet. I just saw that pop up
No, that's
in
good.
there.
I'm glad you answered. And there's another one too. Have any patients been able to be approved by Health Canada to receive Nuvalent 655 through the special
Yes,
access program? So I think, yeah,
yes,
you did
yes. We
cover
we
that.
Edmonton has at least one that got approved. We have three that got approved, which is why I know that right now they're requesting lorlatinib and chemo. And so we managed to get a patient through without chemo, and we managed to get another patient through without lorlatinib. But we have to put in very, very specific conditions of why we think this patient would suffer from receiving those drugs. And you can't use the argument it's too expensive to buy. They won't buy that. It has to be a medical reason. And we'll figure that out with you and your oncologist. Again, that has to be a private conversation.
And then related to that, actually, so you're talking about the private oncologist or maybe the local oncologist. When a trial is happening, and maybe you can even talk about when we're under a special access program situation, what is the local oncologist's role while a trial or a special access program is happening?
So there are two different things. In a clinical trial, the clinical trial has to be performed at a specific site. We don't currently have what we call virtual trials where patients are seen somewhere else and then they're still part of the trial. Until the regulatory agencies in the US in particular, but also around the world, accept those types of trials, we won't be able to conduct them. And so during a clinical trial, patients will have to show up at a site for the clinical trial that has a clinical trial open. So for us, for instance, we make sure that patients will at least get reimbursement of money for their travel by coming here. So if they live in Northern Ontario, they get a Northern Ontario grant, so the government pays for it. But we've been able to reimburse people coming from Montreal and Ottawa and other places, as well the travel costs in general if they're reasonable in this setting, which includes hotel costs and so forth as part of the trial. But the problem is they have to fly in and oftentimes or take the train. And oftentimes they come a lot at the beginning. And then as time goes on, they show up less and less because, it's found to be safe in them. In a special access program, it's different. Some special access programs are open such that anyone can request, like any oncologist can request the drug. Because this is such an early phase drug right now, there's a restriction by both the company and Health Canada that it needs to be someone who is experienced with this drug. So as I said, there are 4 centers around Canada, and we're happy to chaperone local oncologists. So the local oncologist will be the one to draw the blood, to see the patient, to do all of that. We might need to do the periodic phone call with the patient. We might need to have email communication with the local oncologist to make sure that they're monitoring correctly, they're doing everything correctly, and to make sure it's safe for all of our patients. But we can do that now outside of a clinical trial where the patient does not have to travel.
That's great to
Right. And
hear.
it's a free service, because it's not
Mhm.
like I can bill Alberta or bill, not that I bill anyway, I'm salaried, but as I said, I think it's important to give equal access. Equity is a really important thing for me. I'm sure it is for all of you. And so I don't want someone living in a rural area in an underprivileged province, maybe the best way for me to call that, for them not to have the same access as much as possible to what someone living next door to my institution would have.
Yeah, equal care for everyone, regardless of where they live. And we are such a big country that, you really feel it in a nation like this as well. So,
Mhm.
in terms of, you quickly touched on virtual trial. Have you ever seen that in another country, or
I
it
haven't
doesn't really
seen it
exist? Okay.
directly. There's some discussions about this. One of the problems is that virtual trials right now are not accepted by the regulatory agencies in many countries. So that's the problem, right? So when the FDA, because everyone wants their drug in the US because that's where they make most of the money. So if the FDA says yes, then they're willing to bypass Europe and Canada and everybody else and follow through. So when the FDA starts to say yes, we accept these trials and we know how to monitor them and we know how to make sure that they're safe, then we'll start seeing those trials being developed.
That would be wonderful. Let's hope future.
Mhm.
And then another question. So will patients continue? So I guess I think this is in the context of when you're in a clinical trial. So once patients are on a clinical trial and it's basically kind of sponsored, will they stay on it when the trial closes,
Yeah, the
typically?
general rule of thumb in Canada is thought to be unethical to basically put a little bauble in front of somebody, says, come join the trial, and then pull the rug from under them. So from an ethical perspective, the answer is they're supposed to support and continue to offer the drug, with one exception. If the drug is deemed suddenly to have an unexpected safety issue, like it's killing people, and the drug is entirely withdrawn for that reason, then obviously that's no longer available. Outside of that, the general rules are the company has to guarantee to continue to supply the drug for as long as the patient is benefiting from it, with a few exceptions, one of them being a safety signal. Okay, there's a question out there that I would like to answer that may not be directly related, but I want to make sure I answer it because it's really important. And the question is do we use biomarkers, and how often do we use it? When do we use it? In general, I think these days it makes sense that at any time in which the drug that you're on right now, the tyrosine kinase inhibitor, the targeted drug that you're on right now, seems to have stopped working in one part of the body or in multiple parts of the body, it may be very reasonable to consider a rebiopsy or to do what we call liquid biopsy, so a blood test, to try to identify additional mutations that may have developed or additional molecular changes that would have developed to explain why the drug is no longer working, which may guide us in terms of determining what other drug or other drug combination might be useful in a patient. So in general, if you're receiving chemo, it's not thought to be targeted, so we don't necessarily think that doing a biopsy after you failed chemo makes any sense. But if you're on one of these targeted drugs, then that drug is selectively killing off certain types of cancer cells. And it may be that as it's killing off the ones that are sensitive to the drug, the ones that are resistant to the drug start to grow out. So eventually the ones that are resistant to the drug take over. And in that case, we might need to rebiopsy in order to figure out what has changed. And then how can we target that drug next? So those things should be at least considered. They're not necessarily done in every setting, nor are they appropriately done. But if you're going to think about this and you're going to badger your oncologist to at least think about it or to consider it, it's whenever the drug that you're on, if it's a targeted drug, seems to stop working.
Okay. Yeah. And I think access to the blood biopsy, it could be a potential barrier, but I'm glad we have the recommendation to actually have that conversation with your oncologist.
Sometimes it may be worthwhile to actually pay out of pocket for it. Sometimes we have tried, like for instance, at Princess Margaret, if you show up at our doorstep right now, we will draw your blood and we will do the test. We thank our donors. We thank the persistence of my colleagues in getting companies to donate, free tests and so forth for it. We don't know how long it'll last. So there are different mechanisms and ways. Again, we encourage people to explore that with their oncologists and to check the larger centers to see if some of us may have the opportunity to get quote unquote free tests here and there.
Okay, I do have a couple questions coming in. I think we can answer them right now. Would you do both tissue and blood biopsy? Or maybe you can tell us when you would do one versus the other.
If I could, I'd do both. All right. But in some cases, that's not an option. I try to get tissue if at all possible. Sometimes there's nothing to biopsy. Like it's too difficult. It's in the bone, it's in the brain, right? And so there's nothing easy to biopsy, or it's too dangerous to biopsy. So under those conditions, I push for the blood. If I had my druthers, I do both in every single patient, because there's some things we cannot detect in the blood. And the blood is not quite as sensitive. So sometimes we'll miss something in the blood, but we'll catch it in the tumor. And sometimes vice versa. So if I could, I would do both. But if not, I do at least one.
Perfect. Okay, so I know we're at the time. Do you have time for two questions and we can make them
Yes.
quick? Okay.
Yes.
In terms of next steps, or could you say more about the ALK trials coming to Canada? You briefly touched on them. So is there a way we can stay up to date? Is there anything you can kind of close off with on that?
So here's the issue, right? The current drugs that have gone through or going through right now, lorlatinib and eladactib, they're particularly really effective. So patients are often on it for years already. So it's harder for companies to develop kind of the next drug. when they know that these drugs are so effective already. So what the new drugs are basically what I call dirty ALK drugs. They target ALK and a bunch of other things because we feel that when you have drugs that are so effective, these drugs start working when the tumor finds a way to bypass the ALK and use some other pathway to bypass it. So you need to be able to target the ALK and the other pathway. You need to target both. So these drugs are really targeting what we call multiple targets at the same time. And we think that may be where the next generation will go to. They're coming as first-in-man drugs. So there's nothing right now that is that is active that we can get our hands on right now in Canada. But we're working on getting some of these drugs. We're still working to try to get the vaccine. There are a whole bunch of new rules, which I won't get into, that are barriers to the system outside of the U.S. So yes, we're working on all of these. I think the best way to do this is as soon as we have any information and so forth, I release it to Katie and Duncan. We come up with a balanced statement so it doesn't make people too excited or and so forth, but at least to give them information that's useful about what may be coming. Does that sound reasonable?
Wonderful. Absolutely. That
Okay.
sounds great. And our last question is, what would you recommend, kind of related in a way, but how would you recommend we as patients and caregivers best advocate for second line coverage of TKIs in Canada?
So one of the things that I've learned is that you guys have so many special talents. Some of you are politically connected. Some of you know friends who are politically connected. Some of you are very scientifically based. Some of you are very creative. Some of you work in media, right? I think we need to put our heads together to figure out, how do we get into the minds of our politicians? How do we get into the minds of the bureaucrats? And because healthcare is provincial, we need to do this province by province, bit by bit. So I think the best thing for me to say is stay tuned because I think I'm trying to meet with Katie and Duncan to come up with some initial strategies, and then they'll reach out to all of you for all of your talents. Because that's the one thing that I've learned. I don't know any politicians. They're just not in my circle. I don't know any bureaucrats. They're not in my circle. But who knows? Maybe one or more of you or your friends or your families are connected in different ways. So we're going to rely on, your expertise and your agenda. Groups such as Lung Health Foundation and other groups are very good at also training patient advocates as well. So the more of you that are out there, the more we might be able to get our message through that we need more access to drugs. It's the right thing to do. It's the equitable thing to do.
Fantastic. I think that's a perfect way to end the session. I definitely think that here with ALK Positive Canada, this whole community here, we're definitely showing up stronger and more of a collective this year. And so definitely look forward to pushing through and with your assistance, Jeff, as well. So thank you so much. We've gone over the hour. Don't want to take any more of your time. I want to thank everyone else for jumping in and joining. We will be sending an email out with a survey. We would love to get your feedback, love to learn what you would like this year and in terms of programming and events. So look out for that email with the recording and a survey. In terms of connecting with ALK Positive Canada, continue doing what you're doing through Instagram, Facebook, the private Facebook group, and LinkedIn. Continue the conversation there. Today, we can answer each other's questions as well. And the last call to action would just be if you want to do a meetup in your local area, we're happy to help, coordinate maybe on the Facebook group. But please do it. I think it's really rewarding and it's been rewarding so far. So I'll leave it there. Jeff, before we close off, do you have anything else you want to add or?
I'm going to say just one thing very, very controversial, right? We Canadians are overly polite. We don't want to rock the boat. I certainly don't, it's taken me years to realize this. This is the one thing in which we need to be more American. We need to stand up. We need to be vocal, right? If we learn anything from the Americans, this is what we need to be if we're going to effect change, right? And I feel over the last few years, there've been, errors made along the way in terms of drug access and so forth. And it's up to us to fix it. It's up to you guys to fix it because it may directly affect many of you. moving forward. So let's work together and try to figure out how we can be less polite and more vocal about what is right.
Wonderful. Thank you so much. Duncan, did you want to say anything?
No, thanks, Jeff, for a wonderful presentation. And you're right, we need to work together. And we're going to start tomorrow morning.
Great.
Wonderful. Thank you so much, everyone. Thanks, Jeff, for your time. Thanks, Duncan, for kicking us off. See you online.